Hi everybody, I'm Dr. Richard Mackool, and I'm here with Thomas and his mother Donna Sacamano. Thomas suffers from Duchenne's muscular dystrophy. He's one of the older boys with the condition. He's 30 years old. He's been on steroids for a long time, as are used for the condition, and that's caused him to develop severe cataracts that have greatly limited his vision, actually making him legally blind. His mother, Donna, has been totally devoted to his care, and thus Tom is with us today to get his vision improved by cataract surgery. His mother is the co-founder of an organization, and I'll ask her to say a few words about that.
Hi. Yes, in 1995, Thomas was diagnosed with Duchenne muscular dystrophy, and I co-founded an organization called Parent Project Muscular Dystrophy, a nonprofit organization with another very dear friend and nurse, Pat Furlong, and who also had two sons with the disease. And we decided at that time we were going to unturn every stone there is for treatment and cure for our sons. And we took measures, steroid use being one of them, to give our sons maximum function, which it did. And of course, with side effects, Thomas has really had very diminished eyesight. And I am thrilled that we found Dr. Mackool, who took on his case when others would not, without anesthesia, without general anesthesia or sedation, and restoring Thomas's vision, which is a wonderful thing. Avid football fan and DJ, he's getting back to business. So thank you, Dr. Mackool.
Oh, it's a great pleasure to be able to do anything that I can to help you folks. So how you doing, Tom?
I'm good.
You're up for this?
Yep, I'm ready.
All right.
We're gonna win one for the Gipper, are we?
Yeah, I'm ready.
All right. Tom's a brave young boy. There'll be some important things that we have to pay attention to for patients with medical conditions such as this one. Thomas, for example, can't lie very flat for very long. That's a problem. He obviously doesn't have control over all of his musculature, very little of his musculature. So we'll be paying attention to that as well. Anesthesia, we really don't want to sedate him, if at all, because that interferes with his respiratory function. So positioning of the patient is going to be important here. We don't want to hurt him as we do it, of course, and we want to minimize anesthesia. That's going to be the goals, and so off we go to get this done for Tom. Here's Tom in the operating room. He weighs 60 pounds. His mom weighs 90. She's picking him up and carrying him to the table. She knows how to carry him the best. Now we're going to get him into position and make him comfortable before we partially recline the chair, making sure that his breathing is acceptable to him. Here we have the pressurized oxygen delivery system that he uses usually at night and certainly when he lays down. Now he's got his breathing assist apparatus. He's in the sitting position, and we're going to lower the automated OR chair table. And in a moment here, you'll see that as we lower him, we're going to lower him to, he's probably around 20 or 30 degrees of head elevation there. And that works for him. Now, we're going to cover him as we do every patient, but Tom has some claustrophobia. Breathing problems will give that to people. So we're going to elevate the drapes, and you can see they're elevated from his head here, away from me, as I'm preparing his eye for the surgery, putting the drapes on. So you can see the extreme density of the posterior subcapsular opacity here. We'll be using trypan blue to be able to visualize the anterior capsule. And I'm using alkane or proparacaine with cotton tip applicators to get some anesthesia. There's no sedation whatsoever, so there may be a tendency for him to move a bit. You're doing great. I'm going to mark his 90-degree axis because that's essentially where I'm making penetrating limbo relaxing incisions. Okay, nice and still, right there. Hold it real still. Bingo. Our plan is to put a Restore 2.5 multifocal lens in Tom. He obviously is not able to be putting glasses off and on all day. Good, nice and still. I'm going to hold him as still as I can. And when I get him right, then I'll make the side port puncture in and out quickly. Same thing, back toward the lights, Tom. Good, nice and still, just like that. Okay, and now we'll stain his anterior capsule. That was a 2.4 millimeter keratome. So air, trypan, let it sit for a few seconds. A little sting for a few seconds, Tom, intraocular lidocaine. That'll stop stinging very soon. All right, best to keep both eyes open. Good job, just like that, Tom. Viscode injected distal to the air bubble. And if his eye moves, I'm following it, but I'm kind of controlling it. Good. Spatula. I want to do as little one-handed as I can. So even now when I open the anterior capsule, I want to put a spatula in. And I'm going to open the anterior capsule with the Provis cannula. I'm not going to inject much Provis. Nice and still, Tom. So I just made a little slit in that capsule. Wet the cornea. Good. So you can't tell, but I can. He's got recurrent Bell's phenomenon. The eye wants to rotate up, but it really can't because of my spatula. And I'm using high mag so I can see the capsule, because even with the trypan blue, the red reflex is so poor that it's not easy to see it in all locations. So just completing the capsule axis here. Okay, we're now ready to do hydrodissection. Again, I'm trying to do that by maintaining globe position with my left hand. And that was a pretty easy hydrodissection. Come over here and do a little more there. Okay. Now we'll do viscodissection. You know, if you practice using syringes with one hand, when you get into situations where you kind of have to do it, you'll be a bit more comfortable. So I got viscodissection here for 180 degrees or more. And now we're ready to go to phaco. So I'm going to come out and test my infusion here. You're going to feel a lot of water on your eye, Tom?
Yeah.
Good. You can see how severe the Bell's phenomenon can be. But I'm going to sneak in there like that. Now I can move his eye down. Spatula's in there, so I've got bimanual control of eye position here. And probably has a bit of a nuclear density here. Been on steroids a long time, so it clearly has a dense PSC. So let me pop in here with this. I can't quite get that in yet, but I think we will in a second. Give me a side port blade. I think I'll just make that a tad bigger. That little puncture. Position 1, and want to get in the same little puncture there. Wiggle it a little bit to get it in. There we go. And then make it just a little bigger. Okay. And now we're in. What's cornea? How you doing, Tom? You good?
Yeah, water's cold.
It is cold. We bring it down from the mountains, you know. Just checking to see if it's choppable yet. Not quite. Now, he's got a really deep chamber, so I'm at a pretty severe angle. So I'm going to sculpt very carefully here. Good. And there we got a chop. Now, see that, folks? This is an interesting phenomenon. That's water that just got on the undersurface of the lens. So what I'm going to do is wipe it off. So can I have somebody come here with a cloth and wipe the undersurface of the lens? And I'm going to come out while we do that because the visibility is just not so good. That's a big water bubble that just happened to splash up on the undersurface of the microscope lens. All right, come on over and wipe it with the regular cloth. I'm going to take the microscope away from the patient so that my nurse can do that. You can look underneath there, see if you're getting it. Got it? So, I hadn't told you, but we have the Aura device on here, and that puts the lens down closer to the patient's eye. So if you get a little bit of upshot of fluid from the eye, then you can get it on the lens of your microscope. All right, so quadrant removal. The center of the nucleus was somewhat dense, but the periphery not so much. And get this piece here. And wet the cornea. So a heminucleus has been removed. And we're down to the last quadrant here. You can kind of see how floppy the iris is. You know, the musculature of the iris probably isn't quite up to snuff either, but we're good. I've got right underneath the subincisional area here, kind of a little piece of cortical stuff, and I think we'll remove that with the INA tip. So that his iris doesn't prolapse, I'm lowering intraocular pressure before I come out. And now we'll go to INA. So there's our 90-degree INA tip, testing infusion, rotating the sleeve. Okay, Tom, try to look straight ahead. Slip in here. So I now have that piece of lens material that was subincisional. And I'm just going to press that into the port and get rid of it. So now we'll remove the cortex. And that little bubble's in the way, let's take that. So now last, I'm going to take out some epithelium underneath the anterior capsule. Pretty obvious where it was when it becomes clear. And now we'll lower IOP again. Let's just go to position 0. So what you do with floppy irises, IFUS, whatever the cause here, muscular dystrophy, same thing. Lower IOP before removing the instruments. And now I'm going to inflate the globe with hyaluronic acid, Provisc, and we'll take an Aura reading. Still too low. Super deep chamber here. We're going to do a little stromal hydration right at the light time. So that we can maintain IOP a little better. At the light, Tom. Good. See those 3 little lights? Pick out your favorite. Try to look at one of them. Good. And an IOP check. Just still a little too soft, perhaps. But just a little more fluid, and then I think we'll be good to go. Yeah, that feels good to my finger. Let's see what it is to this device. Good. Okay, let's take an aura reading. Tom, I'm going to be turning out the light. When I do, you'll be able to see a little red light.
Okay.
And I'll need you to look at the little red light, okay? Okay, now look right at it, dead center. Okay.
20 we
Right
go
on the
for
number.
19.5.
Yeah, we'll go with 19.5.
Okay, 19.5.
Good. So the aura is calling for somewhere between a 19.5 and a 20, and our plan is 19.5, and so we'll go right with that. And the reason it may be calling for a 20 is the pressure just slightly lower, so it'll ask for a little bit higher IOL if your IOP is just a little low. Spatula. Look straight at the light, Tom. Good. So now we're going to put this Restore 2.5 IOL directly into the capsular sac. And tuck it in there before it unfolds. So now we're ready to remove OVD from behind it. But I'm going to leave the OVD in front of it and irrigate that out. You may need the chopper to release that haptic. Doing great, Tom. We'll be done in just a couple minutes. But I'm going to do the limbo relaxing incisions before I do that. So there's one mark right there, and that's where I'm going to do. Straight ahead now, Tom, nice and still. Good. One of the 2.75 millimeter limbo relaxing incisions. And then I'm going to sneak around to the other side. And here I'm going to have to change hands.
Yeah.
Because of the aura. Straight at the light, Tom. And I want to have IOP elevated when I make these incisions, so in we go, change hands, right on my little mark there. Wiggle to get in slowly and out. Good. Right at the light, Tom. So now it's time to remove OVD. First from behind, and then I'm going to remove it from in front using a syringe. Right at the light, Tom. Straight at the light, Tom. So we'll just take our time here and hydrate the little side port incision. Then the primary incision. Okay, nice and still. And irrigate the angle. Now, you saw IOP went up, iris prolapse. I'm not going to try and push that back in. I'm going to come over here and aspirate. Lower IOP. And then, look straight ahead, Tom, nice and still. Then it's easy to reposit it. Let me have a little OVD. Just going to gently massage the iris into position and go back and do more stromal hydration. So when you do get iris prolapse, what you want to do is nice and still. Can't do it yet. Look straight at the light, Tom. Nice and still. What you want to do is lower IOP before you try and put it back in. And I have to wait for just the right moments because the motions of the globe are making it a little tricky. Straight at the light, Tom. Slowly increasing IOP here. And deepening chamber. And look down a little. Almost normal depth chamber here. Big syringe. Yep. I need you to look straight ahead though, just for a couple minutes while I do what I'm doing. Because when your eyes moving, I just kind of have to delay doing stuff. And last of all, we got to put in the vancomycin. Vancomycin. And dry sponges. Right at the light, Tom. Still now. Good. Gonna increase his IOP just a little bit more. It's just about normal. Straight at the light, Tom. Good, hold it. Excellent. And we're done. All good? All right. So you'll be able to see better like immediately. See my hands and everything. That was one big cataract.
Bye-bye. Thank you, everyone. Thank you.
So we're back here with Tom and his mother. We're now 2 months since Tom's had his surgical procedures to correct his vision, and things have gone quite well. Let Tom tell us all about it, but it's been an awfully nice thing for all of us to watch Tom regain his sight. So, Tom, how are things from your perspective?
Really good. I can DJ again and watch. I watch football on TV, and I can see my cell phone and computer and the signs in the car, like the traffic signs and all that stuff, and I can see people more clearly. Like the details instead of just like people. I can see the details on the people.
You know who they are, huh?
Yeah.
So Donna, what's happening from your perspective with Tom?
Well, you know, I was with the turn downs we got from a few surgeons, I was really, you know, losing hope that, you know, Thomas was going to see again and get to do all the important things that were, you know, that he used to do. Again, his music is very important to him. You know, he enjoyed DJing. He's really good at it, and you know, big sports fan. Watching sports and taking that away was really terrible. But now, you know, that's all returned, and I actually have to remember that he can see, because in the car he's telling me where to turn and how to go, because I forgot that he, you know, he can see now. So yeah, so I'm just overall quality of life is so much improved, and it's just
The multifocal
wonderful.
lens is working pretty well for him, I think, huh? He's got close vision
Yes,
as well
I'm
as
very
distance.
jealous. You can see fine near.
Yeah, he's got better vision than us.
He does. Yes.
Well, darn it.
Yeah.
That happened.
Yeah. I guess what's important to me as a mom is that, you know, Thomas didn't even consider this a quote unquote surgery. He thinks of it as a procedure because it was so easy, and you know, it didn't require
Non-invasive.
non-invasive, and it didn't require, you know, such a concentration on his limitations, cardiac, respiratory, that it was really quite amazing for us, and I'm so grateful for it.
Well, I'm so grateful that technology has come along to enable this, because it wasn't that many years ago when this wouldn't have been possible from an anesthesia point of view, from a cataract removal point of view, from an intraocular lens point of view,
Yeah.
we'd have had some huge compromises and less chance for this type of success. So a big effort from a lot of people around the great land that made this possible for Tom, and way to go, everybody.
Right. Yeah.
Wonderful. Thank you.
Thank you.
Thanks.
Yes, thanks.